Hello and welcome to this fourth year lecture. This lecture will be on urinary tract infections. Please ensure that you use this PowerPoint presentation in conjunction with your lecture notes. There is an important
All
part with
children
regards to the
under the
management of
age of 2
UTIs that is
years
often
with an
forgotten when we
accurate
look at the
diagnosis
pediatric
of a
population.
UTI
So to help
need
you
a
remember this fact, I've
KUB
enlisted the help of a few
ultrasound.
characters throughout this lecture to remind you of this important fact. So let's start with the first one.
All children under the age of 2 years with an accurate diagnosis of a UTI need a KUB ultrasound.
So let's go through that again. All children under the age of 2 years with an accurate diagnosis of a UTI will need a K, so kidney, U, ureter, and B, bladder ultrasound. In addition to getting rapid control of the infection, it is important to exclude underlying abnormalities of the urinary tract so that you prevent renal damage and prevent potentially these patients progressing into chronic renal failure. All right, so how do we then make an accurate diagnosis of a urinary tract infection? So obviously it all starts with your history and your clinical picture. So why do the parents present to you? So unfortunately, in your children under 2 years, the signs are very non-specific. They can present with just fever, they can present with irritability, not feeding well, vomiting, diarrhea. In your neonatal period, they can even present with jaundice. And if it progresses or they've had recurrent infection, they could even present for the first time with renal failure. Your children older than 4 years tend to have more specific symptoms, similar to those that we see in adults. So they can present with either upper tract or lower tract signs. Your upper tract signs is fever, abdominal or lumbar pain, and vomiting. Your lower tract signs will be your dysuria, your frequency, urgency, and incontinence. Between 2 to 4 years, it will depend on the development of your patient, and it will be anything from your non-specific clinical features to your more typical specific clinical features that you would see in adults. All right, so how do we then actually make an accurate diagnosis of a urinary tract infection? Your history and clinical examination should give you a clue to suggest that this could be a UTI. However, in your smaller children, as we've already mentioned, especially those under 2, your signs are very non-specific. So you need to have a high index of suspicion for a UTI in these patients. So the first thing that you can do as a screening is to do your urine dipstick. When you assess your patient or when you do the urine dipstick, there are various things that you can test on the urine dipstick, but the two things we look at specifically for infection is nitrites and leukocytes. So on the next slide, I will show you the combination of the two when you would suspect a likelihood of a urinary tract infection. If you do suspect, then please send a reliable sample for urine MC&S. So what is considered a reliable sample? Suprapubic aspirate, in-out catheter, midstream urine sample collection. Bag samples are not a reliable specimen to send away for urine MC&S. There's too much contamination, so please do not waste your time. If you're struggling to get urine from a patient, you can use a bag sample as a screening. If it's negative, great, but if there's leukocytes or nitrites, you need to get a reliable sample and repeat your testing. Very important to mention, if you're doing midstream, if it's a girl, they need to clean properly, the mother needs to separate the labia, and you need to try and catch a midstream sample. If it's a boy, you need to clean, retract the foreskin if you can, clean properly, and collect your sample. What I always recommend is to always have your specimen jar ready for collection, because a lot of the times just after you've cleaned, the patient decides to urinate, and that's the perfect opportunity to collect a midstream sample. How are we going to interpret the urine dipstick test? If you see leukocytes and nitrites, there is an 85% likelihood of infection. Do a urine MCNS, treat as an infection. If there are no leukocytes or nitrites and you have a low index of suspicion for an infection, infection is unlikely. However, use your clinical judgment. If you still have a high index of suspicion for an infection, send away a urine MCNS. If you have leukocytes but no nitrites, infection is probable. Do a urine MCNS and treat as a urinary tract infection until your results are known. Keep in mind, if a patient has received antibiotics before you've collected your urine sample, this can interfere with the results you will find on your urine MCNS. If you see nitrites but no leukocytes, make sure there is not stool contamination, especially if it was a bag sample. If it was a bag sample, repeat with a reliable specimen. If you still get nitrites on your dipstick, send away urine MCNS and treat. It's important to note that nitrites are actually quite rare in children under the age of 2. In order for nitrite to form, there needs to be a dwell time in the bladder of at least 3 hours or more. In a child who is not yet potty trained, you should not have a dwell time of at least 3 hours in your bladder. If you do, you need to think of obstruction, and these are the patients that will need further imaging. Alright, so you've sent away your urine MCNS. How are you going to interpret the results? So you need to be able to look at this and decide, is this an accurate diagnosis? So the first thing first, make sure you sent away a reliable specimen. After that, you need to then look at the specific values of your result. So the first thing you're going to look at is your leukocyte count, and that needs to be significant. So your leukocyte count needs to be more than 10,000. Things that might complicate this result is prior antibiotic use. Therefore, you then need to treat your results with caution. After you look at your leukocytes, you need to actually look and see, did you culture an organism? What's important with the culture is that it should be a single organism. As soon as you culture more than one organism, you need to think that there was possible contamination. And then when we look at that organism, you need to look at the bacterial count of that organism. So it needs to be a specific number. And the bacterial count will depend on the type of urine specimen that you've sent off. For a suprapubic aspirate, any count more than 1,000 is significant. For a catheter sample, more than 10,000. And for a midstream urine sample, any bacterial count or growth more than 100,000 organisms per mole. Right, so let's see if you remember that phrase. So I would suggest that you all say it with me. When you say it, it helps to stick in your brain a little bit longer. So let's see if you remember the phrase.
Ultrasound. All children under the age of 2 years with an accurate diagnosis of a UTI need a KUB ultrasound.
Right, so as you heard, if you're under 2 and you have an accurate diagnosis of a UTI, please make sure that you do imaging on these children. Other indications for doing the KUB ultrasound is if you have recurrent febrile urinary tract infections, regardless of the age, a child of any age who has a UTI and has poor growth, you find them to be hypertensive, or they have a family history of renal or urological disease. The other indication will be a child who does not respond as expected to the appropriate antimicrobial therapy. You need to exclude that this has perhaps not progressed to an upper tract infection, or that they perhaps has complicated with an abscess. When do you do the ultrasounds? So for the last point that we've mentioned, if they don't respond appropriately for antibiotics, you need to do it urgently. If you suspect an obstruction, so a patient who has nitrites on the dipstick, on clinical exam had a palpable bladder in a child who's not potty trained, or if you have a history that fits with possible obstruction, poor urine stream, poor urine flow, those are the ones that need urgent ultrasounds. For the others, it's best to wait until your urinary tract infection has cleared so that it doesn't interfere with the findings that you see on your ultrasound. In addition to the ultrasound, there will be a few patients that will need further imaging. So in these patients, your two options are avoiding cystourethrogram or isotope renogram, a MAG3 scan. The indications for these are patients who have recurrent urinary tract infections, as we need to exclude reflux. If your ultrasound shows dilatation of your upper tracts, or you have bladder dysfunction, and if you had upper tract involvement. The choice of the two is basically based on the child's age. If they are older than 4, then you can ask for a MAG3 scan because these children need to be able to micturate on request. Make sure you ask the radiologist to do an indirect cystogram to check for reflux before and during voiding. If you do not have access to an isotope study, a VCU can be done instead. When we look at the timing of these tests, it's important to do it about 4 to 6 weeks after the initial diagnosis. If you require it urgently, in other words, you suspect obstruction, you need to make sure that the urine MCNS is sterile. Repeat it and make sure that there is no growth, and you do it while they are still on antibiotics or prophylaxis. If you do it while they have an active urinary tract infection, you can spread the infection. Other investigations that you need to consider other than imaging. We don't do these in all your patients that are diagnosed with urinary tract infection, but you will consider this in a child who is systemically ill and in all children under the age of 3 months. So in these patients, you should consider doing a urea, electrolytes and creatinine, a CRP, and a blood culture. So let's look at the management of these patients. Before we talk about antibiotics, let's talk about a few general measures. Please exclude obstruction. So good history, good clinical exam, and your urine dipsticks. If you think there's obstruction, please do an urgent ultrasound. When we look at the fluids, it's important to remember that if you have upper tract involvement, this will reduce the tubular concentrating ability and you get inappropriate polyuria, and you need to make up for these losses. So in addition to your normal maintenance that you are going to give this patient, you need to add an extra 33% to this volume. If they're feverish, consider an antipyretic, but please avoid your non-steroidal anti-inflammatory drugs, as these have a high risk of causing acute kidney injury in dehydrated patients. If you have an older patient who is complaining of dysuria, you can give some Sodabig to alkalinize the urine just to provide some symptomatic relief. But this is contraindicated in patients who have a Proteus infection. And then just remember that if you need to do an urgent VCU, make sure that you repeat a urine MCNS before doing so. If we look at antibiotics, you need to make a choice and decide whether you are going to give the antibiotics intravenously or whether you're going to give oral antibiotics. The indications for intravenous antibiotics are your young patients, so those under 3 months of age, if you suspect that there's upper tract involvement, and if there is uncontrolled vomiting. And your choice that we use will depend on the sensitivities of organisms in your area. In Bloemfontein, we can use Augmentin or a 2nd or 3rd generation cephalosporin. Remember to follow up your urine MCNS results and make sure that the organism you culture is sensitive to these antibiotics. If not, you need to change accordingly. The total duration of antibiotics should be between 5 and 10 days, but as soon as they are afebrile for more than 48 hours and they are no longer vomiting, you can switch to oral antibiotics. The choice for oral antibiotics is also Augmentin. You can use cefuroxime or you can use ciprofloxacin. And once again, please check your urine MCNS to see that your organism is sensitive to the antibiotic you are using. Prophylactic antibiotics, current recommendations says to rather monitor closely and treat new infections rather than giving long-term prophylaxis. You need to individualize for your patients, and your choice of antibiotic will be guided by the sensitivities of your previous cultures. And there are a few choices that you can use. The indications are reflux, if you have an obstruction that is uncorrected, and if you have renal scarring that's confirmed on your isotope scan. There are certain conditions that will predispose patients for recurrent infections. In patients with constipation, the stools will place pressure on the urethra, therefore causing incomplete emptying of the bladder. You'll get stasis of urine, and this will lead to infection. Make sure that your patients are treated prophylactically with mebendazole so that you avoid any pinworm infestations. Patients with reflux, as well as obstructions of the urinary tract, whether it's functional or anatomical, are also at risk for recurrent infections. In patients with recurrent infections, it's important to counsel the parent as well as the patient, if they're old enough, about certain things that they can do to limit the recurrence of urinary tract infections. A few things to avoid are things like constipation, perfumed bath salts, bubble baths, bath oils. These tend to cause a lot of irritation to the perineum, as well as looking at the type of detergents that they use to wash their underwear. The green sunlight bath soap is generally something that is very neutral and safe to wash underwear. Things that you want to encourage. In boys with structural or voiding abnormalities, we strongly recommend circumcision. Good perineal hygiene is very important, especially in girls. Teach them to wipe correctly from the front to the back. Using pure cotton underwear, making sure that you take a lot of extra fluids in, and make sure that you go to the toilet and you void frequently and regularly. In some instances, you might even need to write a letter to the child's school to explain the child's condition if you have permission from the parent to do so, so that they understand why the child might need to go to the bathroom more often than normal. Some schools have a very strict policy with regards to going to the toilet during class times. Which patients are you going to refer? Urinary tract infections are common, and most of them, as a GP, you will be able to manage. But there are certain cases which you need to consider referral. If you have recurrent infections, reflux, voiding disorders, structural abnormalities, or renal function impairment. All right, last character. What was that phrase again? I'm going to give you a few seconds to see if you remember it, and then I'll play the video. Alright, so thank you for listening to this lecture. I really hope that you've learned something in this lecture. It is an important lecture. I'm sure most lecturers will say that about all of their lectures, but urinary tract infections is something that we see very often in pediatrics, and it's something that you will probably see often as a GP. And as I mentioned in the beginning, rapid control of the infection, exclude underlying abnormalities so that you prevent permanent renal damage for these patients. Thank you.